The exam is going clinical and we are ready for it. Dear students, I am Dr. Malcolm, your faculty of dermatology at Marrow. So in this session, we'll be discussing various clinical vignettes in dermatology. So in the exam, we are going to be encountering a situation where a patient and the clinical situation is given to us. Okay, and we know that dermatology can be pretty confusing with relation to the shapes, distribution, size. So I'm going to go in an algorithmic fashion and teach you as to how you can narrow down your differential diagnosis to arrive at the right answer. So when we're discussing clinical vignettes, we'll begin with the first topic of clinical dermatology. Case scenario number 1. An adult presenting with an annular plaque with central clearing. So we already know in dermatology, annular is a ring-shaped lesion. So the word annular means a ring-shaped lesion which is generally active in its periphery. Two important differential diagnoses to consider. Number 1, tinea corporis. Tinea corporis. Second important differential diagnosis here is granuloma annulare. Granuloma annulare. Now, how do we distinguish these two conditions in the exam? Number 1, when we look at tinea, very important, you can see the border of this lesion. So you see the border of this lesion is scaly. So you get a scaly, well-defined margin. And please remember students, tinea or dermatophytosis is an itchy condition. So pruritus will be present. And how will I confirm my diagnosis? All I have to do is a 10% potassium hydroxide mount and I will be able to visualize the branching filaments of the dermatophytes. Whereas when I look at granuloma annulare, again the annular plaque, again the central clearing, then how will I distinguish? Very, very important, granuloma annulare is an asymptomatic condition. So there is no itching here. So this is number 1. Number 2, very, very important, there is no scaling here. So no scaling, no itching. These are the two important no's for granuloma annulare, which will help us to distinguish from tinea corporis. And please remember, generally, the site of distribution is going to be on the dorsum of the extremities. Dorsum of the extremities. And then what is this condition associated with? It is associated with diabetes mellitus. It is associated with diabetes mellitus. An additional point to remember, what is granuloma annulare? It is classified as a necrobiotic disorder. It is classified as a necrobiotic disorder. Necrobiosis, what does it mean? Necrobiosis means collagen degeneration. Necrobiosis means collagen degeneration. Second case scenario, an adult male or a female presenting with a papulosquamous eruption. So what do you mean by papulosquamous eruption? Means papules and plaques. Squama means scales. So when papulosquamous lesions are mentioned in the exam, 5 important differential diagnoses we need to consider. Number 1 is psoriasis. Number 2 is lichen planus. Number 3, pityriasis rosea. Number 4, secondary syphilis. And number 5, atopic eczema. Let us take it one by one. So when we look at a patient of psoriasis, what is the lesion of psoriasis? You can see there are red, scaly papules and plaques. So point number 1, patient is going to present with red, scaly papules and plaques. So you can see the smaller ones are called papules, the larger ones are called plaques. The smaller lesions are called papules, bigger lesions are called plaques. So this is point number 1. Point number 2, look at the scales of psoriasis. They are described as silvery white scales. And generally, the distribution of psoriasis is going to be on the extensor aspect of the body. So these are the important points to make a diagnosis of chronic plaque psoriasis. Next, we move on to lichen planus. How is the lesion of lichen planus going to be? We have to remember the 6 P's of lichen planus. It goes like this: purple and pruritic. So color is purple. The symptom is itch, purple and pruritic. Next to polygonal and plain topped. Polygonal and plain topped. And the last 2 P's are papules and plaques. Papules and plaques. So here we can clearly appreciate the multiple purplish lesions, and you can see the distribution, students. It is classically going to be distributed over the flexor surfaces of the body. classical, flexor in distribution. We remember psoriasis is predominantly a extensor disease, lichen planus is predominantly a flexural disease, and always examine the oral cavity, because in 40 to 60% of the patients we can have reticulate lacy white patterns. Reticulate lacy white pattern. Please remember the meaning of the word reticulate. Reticulate means net-like. The word reticulate means net-like pattern. The third important differential diagnosis is pityriasis rosea. Now, while thinking about pityriasis rosea, what are the important points to remember? Number one, the first lesion in pityriasis rosea, as we can see here, is referred to as a herald patch. So, point number one is a herald patch. Point number two, the scales of pityriasis rosea, very difficult to appreciate in this picture. It is going to be described like the collar of a neck. That's why this is referred to as collarette of scales. This is referred to as collarette of scales, and the distribution we can see along the lines of Langer. This is referred to as Christmas tree pattern. This is referred to as Christmas tree pattern. So these will be the points in the exam which will help us to make a diagnosis of pityriasis rosea. The next important differential diagnosis for a papillosquamous eruption is secondary syphilis. Now obviously when I say secondary syphilis, students, please remember there should have been primary syphilis, isn't it? So what history I'm going to ask? We know the ulcer of syphilis is painless. So ask for a painless genital ulcer. So history of a painless genital ulcer has to be elicited. And when you look at the morphology of the rash, you generally get a polymorphic rash. You get a polymorphic symmetric rash, generally asymptomatic, but please remember this point, that very characteristic involvement in the exam is going to be the involvement of the palms and sole. So please remember, almost every patient of secondary syphilis is going to be having the involvement of the palms and sole. That is very, very characteristic of secondary syphilis. And lastly, the fifth important differential diagnosis is atopic eczema. So it can look papillosquamous, but please remember the most important history of atopic eczema will be a history of atopy. Now what is atopy? Please remember it is a localized type 1 hypersensitivity reaction. And just like, for example, in our medicine posting, we ask history of diabetes, hypertension to most of our patients, isn't it? So similarly, in every dermatology case, we ask history of atopy. So atopy can manifest in three systems. Number one, in the upper respiratory tract, it is going to present with recurrent allergic rhinitis. So this is point number one, recurrent allergic rhinitis. Number two, in the lower respiratory tract, the patient is going to present with bronchial asthma. And number three, how is it going to present in the skin? In the skin, it is going to present as atopic dermatitis. It is going to present as atopic dermatitis. Now, the morphology of atopic dermatitis depends on the stage. In the infantile phase, you have face is involved, scalp is involved, and extensors are involved. But please remember, students, that in childhood and in the adult phase, we are going to be having the involvement of the flexures. Flexures get involved. You can get red excoriated scaly plaques. Red excoriated scaly plaques. So this looks like a papillosquamous lesions, red scaly excoriated plaques. But please remember, the most important history we need to know at MBBS level is how to distinguish psoriasis from eczema. Please remember, ask history of oozing. So when I say oozing, that means it is probably referring to an eczematous process. So it's very, very important to ask history of oozing here for the diagnosis of atopic eczema. Next, let us go to the differential diagnosis in bullous disorders. Let's take up a case scenario here. So here, let us take there's an adult male or a female who is going to be presenting with vesiculobullous lesions. So let us see how we should approach a bullous disorder. So when we are doing bullous disorders, let us look at the different levels of fluid collection and their clinical correlation. So here you can see a picture. Epidermis and dermis, and in the epidermis the uppermost layer is stratum corneum, the lowermost layer is stratum basale, and there are three levels of fluid collection which I'm describing in this image. So number one, the first is going to be just below stratum corneum, and this is going to be called as subcorneal bulla. So this is a subcorneal bulla. The next bulla, which is just above the basal layer, is going to be called as suprabasal bulla. It's a suprabasal blister. And then the bulla which is just below the epidermis, this is going to be called as subepidermal blister. This is going to be called as subepidermal blister. So we have subcorneal, suprabasal, subepidermal blister. Now, why are we learning all these levels of the blister? So that it translates into clinical practice. That means we have subcorneal, suprabasal, subepidermal blister. Let us see how a subcorneal blister will be. A subcorneal blister is going to be very flaccid. It ruptures very easily ruptures, and it generally heals with normal skin. It generally heals with normal skin. When you're looking at a suprabasal blister, it is a flaccid bulla. It easily ruptures, and generally the bulla is going to heal with hyperpigmentation. And when you think of a subepidermal blister, which is very deep, you're going to be having a tense blister. Do not rupture easily. Do not rupture easily. It does not rupture easily because it is deeper within the skin and usually heals with hypopigmentation, sometimes even with milia. Small epidermal inclusion cysts can be there, and rarely with even scarring. Rarely can be associated with scar formation. So this is a very, very important table. This table will tell you a lot of information to diagnose in the exam. Now, when a bullous disorder comes in the exam, first you classify it, is it a flaccid bulla or a tense bulla? As soon as you see the word flaccid bulla, the level has to be intraepidermal. And whenever there's a tense bulla, I just now told you, think about subepidermal blistering diseases. And please remember, students, whenever the word intraepidermal comes, always think about the pemphigus group. The pemphigus group, which is the superficial group. And whenever you're thinking of the subepidermal blistering disorders, always think about pemphigoid group, which are the deeper bullous lesions. And one more important disorder which is deeper is dermatitis herpetiformis. Dermatitis herpetiformis. Next is when we talk about a flaccid blister in an autoimmune blistering disorder, if mucosa is spared, then we think of pemphigus foliaceus. And if there is mucosal involvement, then we are going to make a diagnosis of pemphigus vulgaris. Then we are going to make a diagnosis of pemphigus vulgaris. And next, now you can see this is a patient of pemphigus foliaceus. You can see the different lesions over here. These are referred to as scales and crusts. And please remember the distribution of pemphigus foliaceus is very, very important. This is referred to as seborrheic distribution. So what are seborrheic distribution or sites? These are the areas which are rich in sebaceous glands. Like for example, you have the face, scalp, chest, and the upper back. So you're going to have seborrheic lesions, okay, in the distribution of seborrheic areas. And if you look at the slide here, you can see this is the stratum corneum. This is the stratum basale. You can see there's a split just below the stratum corneum. This is called as subcorneal bulla. And if you look at a patient of pemphigus vulgaris, what you see here is you can see this flaccid bullae. So how do I know there is flaccidity? You can see wrinkles on the surface. So this is the flaccid bulla. These bullae are going to rupture, and you can see when they're rupturing, what is happening is they tend to extend. So these are the erosions of pemphigus vulgaris, and because of the process of acantholysis, what is happening? They tend to extend. They tend to extend, no healing. No healing. And then when you look at the histopathology of this patient, you can see that this is going to be the stratum corneum. This is the stratum basale. And we see that the level of the blister is just above the basal layer. This is going to be called as suprabasal split. Suprabasal split. Okay, and then you're going to have few rounded cells over here. These are going to be called as acantholytic cells. So these are going to be called as acantholytic cells, and we see that the basal layer remains intact. It remains attached to the basement membrane zone, and this is going to be called as row of tombstone appearance. Row of tombstone appearance is the histopathology of pemphigus vulgaris. And please remember, students, the investigation of choice in any autoimmune blistering disorder is going to be direct immunofluorescence, because this is the test by which you can visualize the pathogenic autoantibodies as to where, how, and which pattern it's depositing. So in pemphigus vulgaris, please remember, we get IgG3, which is going to be deposited intraepidermally in an intercellular pattern, and this pattern is going to be called as fishnet pattern. This pattern is going to be called as fishnet pattern, very classical for pemphigus vulgaris. Now let us see how do we approach this particular topic of subepidermal blistering disorders, or these TENS bullae. So when you're looking at TENS bullae, we could have three situations. The first situation is a patient who's an elderly patient who's going to be presenting with itchy bullae, which are located on a red base or a urticarial base, located on the limbs and the trunk, and DIF is positive. So if you have a TENS bulla in an older patient which is very, very itchy, we make a diagnosis of bullous pemphigoid. We make a diagnosis of bullous pemphigoid. If there is a patient who has extreme pruritus, pruritus is very, very high, and number two, the patient is going to present with elbow blisters. That means when I say elbow, I'm talking about extensor distribution, and they are group blisters. So when I say grouped, the word herpetiformis comes into the picture, because grouped is the other name for herpetiformis, and there can be association with celiac disease or gluten sensitive enteropathy, and DIF is positive, then my diagnosis is dermatitis herpetiformis. Dermatitis herpetiformis. So students, please remember, dermatitis herpetiformis is a disease which is mediated by immunoglobulin A. Dermatitis because it is extremely pruritic. Herpetiformis is because of the grouped configuration of the lesions. And the third situation is when a child presents with a string of pearls appearance, and it's again a IgA mediated disorder. So this is going to be called as CBDC. CBDC stands for chronic bullous disease of childhood. So chronic bullous disease of childhood. So what we have to do is, now onwards, we are supposed to remember the clinical history and the pattern that will help us to make a diagnosis here. So for example, the first condition was bullous pemphigoid. I just mentioned to you, get a lot of TENS bullae here. You get a lot of TENS bullae mainly on the limbs and extremity. They are very, very pruritic. They are itchy conditions, sometimes on a red base. That's bullous pemphigoid. Dermatitis herpetiformis, extremely pruritic, grouped kind of a pattern which you can see here. Excoriations are seen. This is dermatitis herpetiformis. Please remember, the distribution is generally over the extensor aspects of the body. And here I told you about a disease called as CBDC, chronic bullous disease of childhood. What is the string of pearl pattern? You can see the vesicles which are arranged in an annular pattern. You can see this. Vesicles are arranged in an annular pattern. This has been given a name of string of pearl appearance, also known as cluster of jewel appearance. Next, we look at some clinical scenarios in pigmentary disorder. The first scenario is there is a unilateral lesion which is located on the face since early childhood or birth with no photosensitivity. When this kind of a question comes in the exam, unilateral facial lesion, no photosensitivity since early childhood, we can have two important differential diagnoses in mind. Number one, port wine stain. Number two is going to be nevus of Ota. Number two is going to be nevus of Ota. Now let us see how to distinguish between port wine stain and nevus of Ota. Number one is color. So please remember, students, the most important thing in dermatology is color. The color of port wine stain, as the name says, is purplish red. Nevus of Ota is a ceruloderma, that is, it is a blue color lesion, blue to slate gray. This is going to be blue to slate gray in color. Next is the treatment. The treatment of port wine stain is pulse dye laser. Pulse dye laser. Whereas the treatment of nevus of Ota is Q switched Nd:YAG laser. Q switched Nd:YAG laser, which is mainly for pigment. What is this port wine stain associated with? So if there is a patient with a facial port wine stain with epilepsy in the brain and glaucoma in the eye, so please remember, if there is neurooculocutaneous involvement, then I'm going to be calling it as Sturge-Weber syndrome. then I'm going to be calling it as Sturge-Weber syndrome. Whereas when I talk about nevus of Ota, please remember it is going to be following the first and the second division of the trigeminal nerve. That is why face is involved and sclera is involved in 2/3 of the patients. So 2/3 of the patients are going to be having scleral involvement. Let us now look at the picture of a port wine stain. You can see this unilateral lesion which is there since birth, which is purplish red in color. This is going to be called as a port wine stain. Pulse dye laser is the treatment for this condition. This is nevus of Ota. You can see it follows the first and the second division of the trigeminal nerve. So that is why scleral involvement is seen in 2/3 of the patients. Let's take up case scenario 2 in pigmentary disease. So here there is a patient presenting with a unilateral lesion which is hyperpigmented, located over the chest and the upper shoulder. With these 3 important points, there are 2 important differential diagnoses I would want to consider. Number 1 is going to be Becker's nevus. Number 2, nevus of Ito. Nevus of Ito. So what are the differentiating points here? Number 1, always remember first is the onset. So please remember Becker's nevus is acquired condition. So when I say acquired, it is usually under the influence of the androgens which is going to be active at the time of puberty. So the lesion appears during puberty. Nevus of Ito is seen since birth or early childhood. Birth or early childhood. Second point is the color. So very simple, the color of Becker's is going to be brown to black, whereas the color of nevus of Ito is going to be blue to slate gray. Blue to slate gray. And if you look at the surface of a Becker's nevus, hair is going to be present, hair is going to be absent in nevus of Ito. So that is how we distinguish Becker's nevus and nevus of Ito. So students, please try to learn these conditions like this. So this will help you to easily differentiate between these 2 disorders. So here you can see a Becker's nevus, which is a unilateral lesion, hyperpigmented, hypertrichotic. Hypertrichotic means hair is present, located over the chest and the upper shoulder. And if the question says it is an acquired condition at puberty, your diagnosis is Becker's. Whereas you can see nevus of Ito, it follows the posterior supraclavicular nerve, posterior supraclavicular nerve, and lateral brachial cutaneous nerve. Lateral brachial cutaneous nerve. So the distribution is going to be on the shoulder and the scapular region. Just remember the color of nevus of Ito is going to be blue to slate gray because the problem is in the dermis here. Next, case scenario number 3. This is a hyperpigmented hypertrichotic lesion. So if the exam says this hyperpigmentation, hypertrichosis, 2 important differential diagnoses. Number 1, congenital melanocytic nevus. Congenital melanocytic nevus. Number 2 is Becker's nevus. Number 2 is Becker's nevus. So when I say congenital melanocytic nevus, this is a benign proliferation of the nevus type of melanocyte. Please remember the most important point to distinguish between congenital melanocytic nevus and Becker's is congenital melanocytic nevus is congenital. It is going to be seen since birth, whereas Becker's I've already just now discussed, it is an acquired disorder. And one extra point which was asked in the recent NEET exam is always remember if the size is more than 20 centimeter, we are going to be calling it as giant congenital melanocytic nevus, and these patients always have to be under surveillance. We have to closely look at them because there is a 2 to 5% chance in the future to develop melanoma. So melanoma can be one development in these patients in 2 to 5% when the size of the nevus is going to be more than 20 centimeters. Next, let us look at some appendages and disorders and the case scenarios here. So number 1, case scenario is of a child or an adult presenting with loss of hair. So in the exam, we know loss of hair is called alopecia. And when we're thinking about alopecia, we want to broadly classify them into scarring alopecia and non-scarring alopecia. Scarring alopecia and non-scarring alopecia. So this is the broad categorization. Let us look at some important causes of scarring and non-scarring alopecia. Now under scarring alopecia, the first condition, the question is going to come like this in the exam, students. A child presents with a boggy scalp swelling, easily pluckable hair, and regional lymph nodes are enlarged. And sometimes in the exam, they may also say there's history of contact with the pet. Why do they call this pet in the question? Because the pet is going to tell you zoophilic fungi, zoophilic fungus. And the correct answer for this question is going to be Chirion. Chirion is a type of Tinea capitis, inflammatory type. So this is the first differential diagnosis. Second important differential diagnosis here is scarring alopecia presenting with perifollicular blue-gray hue. So if there's a perifollicular blue-gray hue mentioned, our diagnosis is going to be lichen planopilaris. Lichen planopilaris is the type of lichen planus which involves the hair follicle producing scarring alopecia. And if the question says there is central atrophy plus scarring, periphery shows hyperpigmentation, and the scales are very adherent type, my diagnosis is going to be discoid lupus erythematosus. It's a type of lupus erythematosus which is generally restricted to the skin. It is called as DLE. Now quickly looking, here you can see there's a child presenting with a boggy scalp swelling, easily pluckable hair, regional lymph nodes when you palpate will be enlarged. Diagnosis is Chirion, Tinea capitis, inflammatory type. Second important thing, lichen planopilaris is going to be presenting with perifollicular blue-gray hue. That's the clue to pick up lichen planopilaris. And the key pickup word here is a discoid plaque. So you can see these plaques here. There are multiple discoid plaques. You can see they can present on the scalp. Center shows atrophy plus scarring. Periphery shows hyperpigmentation. And the types of scales which are described here is called as adherent scales. My diagnosis is going to be discoid lupus erythematosus. The second important manifestation of alopecia is non-scarring alopecia. So here, let us take up this clinical scenario. There's a well-defined, smooth, circular patch with complete hair loss. Is suggestive of alopecia areata. Alopecia areata. The second situation which is mentioned here is a bizarre shaped bald patch with broken hairs of varying length. This is giving me a context of a psychiatric illness, and this is going to be called as trichotillomania. Trichotillomania. And sometimes the exam may also say incomplete loss of hair within the patch. So now we understand the difference between these two conditions. The word complete is used. It is alopecia areata. If it is bizarre, incomplete, we are going to think of trichotillomania. The third important situation here is diffuse hair loss after a significant systemic stress. The stress could be COVID-19, it could be malaria, it could be typhoid, it could be pregnancy. Then my diagnosis is going to be telogen effluvium. Telogen effluvium. Effluvium means loss of hair. Effluvium means loss of hair. And the fourth situation here, a child presenting with a grey color scaly patch on the scalp. Now I'm going to make a diagnosis of Tinea capitis grey patch type. Tinea capitis, grey patch type. And lastly, if there's an adult with non-scarring alopecia, but it is a pattern type, and the patient also says there's a genetic factor which is involved, then I'm going to make a diagnosis of androgenetic alopecia. So these were the 5 important causes. Quickly, let's look at the images. Number 1, you can see this well-defined, smooth-surfaced, circular patch with complete loss of hair. Diagnosis is alopecia areata. Sometimes the exam may say pits are present, which are generally going to be superficial, regular, fine pits, that further will add on to my diagnosis of alopecia areata. The second situation here, you can see this bizarre shaped patch. It's bizarre, it's bald, it's made up of broken hairs and incomplete loss of hair within the patch, trichotillomania. The third situation is after a significant stressor like COVID-19, malaria, typhoid, loss of hair is called as telogen effluvium. The fourth situation is a child presenting with a grayish color patch here with easily pluckability of hair. Then my diagnosis is going to be non-inflammatory type of Tinea capitis, which is grey patch type. And lastly, the patterned alopecia, which is going to be male and female pattern alopecia. So please remember, students, in females, what is going to be happening is the frontal hairline is maintained. So in women, generally what happens? The frontal hairline is maintained and there is loss of hair over the central scalp. So central scalp gets involved in females, whereas in males, what is going to happen? there is balding of the vertex, and always remember there is frontotemporal recession. Frontotemporal recession. So these are the important points to diagnose patterned hair loss in men as well as women. Second case scenario, students, in appendages and disorder. Here we have an adult male or a female presenting with erythematous papillopustular eruption on the face. Two important differential diagnoses we need to consider here. Number one, acne vulgaris. Number one, acne vulgaris. The second important DD here is rosacea. Rosacea. Now, how to distinguish between these two conditions? First is photosensitivity. Photosensitivity is a feature of rosacea. This is point number one. Point number two, the classical triggers. So, the classical triggers for rosacea are sunlight, stress, alcohol, spicy food. So these classical triggers are going to be there in rosacea. These classical triggers are going to be absent in a patient of acne. And very important feature to remember here is rosacea generally can have photosensitivity. Photosensitivity is a feature which can be there in rosacea. Now, how will I diagnose acne? So acne, the classical lesion of acne is going to be comedones, the special lesion of acne. And usually the patient's skin in a patient of acne is going to be greasy. So the background is generally greasy background or an oily background of the skin. When I'm thinking of rosacea, three important points come to my mind. Number one, centrofacial erythema. That means the patient generally has this redness mainly on the centrofacial aspect of the face. Second important point is flushing. So the patient feels that not only the face is red, it is also feeling warm. So the warmth component gets added to the redness. We're going to be calling it as flushing. And the third important point here is telangiectasia. The third important point here is telangiectasia. So centrofacial erythema, then telangiectasia and flushing. These are the important points for rosacea. And the sites. Now acne not only involves the face, it can involve the chest. It can also involve the trunk as well, whereas rosacea is strictly a disorder of the central convexities of the face. Central convexities of the face is a very classical distribution of rosacea. This is how we distinguish between these two conditions. Now here you can see a patient who has got comedones. These are going to be called as the whiteheads, also known as closed comedones. You can see some closed comedones here. So comedones are special lesions. They are going to be absent in a patient of rosacea. Whereas rosacea, classically you have centrofacial erythema, telangiectasia. So here you can see there's a lot of redness over here. And if there's associated with warmth, we are going to be calling it as flushing as a feature. Let us take up some scenarios in connective tissue disease. In connective tissue disease, number one, there is an adult female who gives history of Raynaud's phenomena. Now, what is Raynaud's phenomena? Raynaud's phenomena is characterized by episodic vasoconstriction. So, the patient's fingers are going to be going in for pallor, then cyanosis, then rubor. So, pallor, cyanosis and rubor. This is the sequential episodic vasoconstriction which is called as Raynaud's phenomena. So it is going towards connective tissue disease and the skin thickening of the fingers extending proximal to the MCP. So the question is saying the skin thickening of the fingers and it is extending proximal to the MCP. So please remember the other name for skin thickening is scleroderma. So thickening is sclero, skin is derma. So we are thinking about a disorder called as systemic sclerosis. We are thinking about a disorder called as systemic sclerosis, and we know systemic sclerosis is a disorder which is classified into two types: limited cutaneous systemic sclerosis, and the second one is going to be diffuse cutaneous systemic sclerosis. So I'm going to tell you clinically and dermatologically how do I distinguish between these two conditions. Now the first is going to be based on the skin thickening. So based on the skin thickening, please remember students, in limited cutaneous systemic sclerosis, the skin thickening involves distal to the elbow, distal to the knee, and face gets involved. This is called as limited cutaneous systemic sclerosis. Whereas in diffuse cutaneous systemic sclerosis, it is distal. That means distal is already involved. Plus proximal to the elbow, proximal to the elbow, proximal to the knee, and trunk gets involved. So then the process is more diffuse. Let us look at the second point. The second point talks about the relationship between Raynaud's phenomenon and skin thickening. So please remember, Raynaud's phenomena, there's a long history which precedes the skin thickening. So many years before, there would be history of Raynaud's phenomena which is going on, then the skin thickening develops. Whereas here, there's a very short history of Raynaud's phenomena. Generally, within 1 year of starting of Raynaud's phenomena or together with Raynaud's phenomena, skin thickening may start. The most important antibody to remember here for limited cutaneous systemic sclerosis is anti-centromere antibodies. Anti-centromere antibodies. The best way to remember this is the other name for limited cutaneous systemic sclerosis is Crest syndrome. That is calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. From the first letter C, you can remember anti-centromere antibodies for limited cutaneous systemic sclerosis. Whereas for diffuse cutaneous systemic sclerosis, it is going to be anti-SCL70. So anti-SCL70 antibodies are for diffuse cutaneous systemic sclerosis. Case scenario number 2. Here we have an adult presenting with facial lesions and photosensitivity. Generally, these facial lesions are red in color. That is what we need to remember. And this photosensitivity. Two important differential diagnoses to remember. Number 1 is rosacea. Number 1 is going to be rosacea. The second important DD here is, students, systemic lupus erythematosus. What are the key features to distinguish between rosacea and SLE? Now, please remember, students, rosacea is going to be having those classical triggers like sunlight, alcohol, hot beverages, spicy food. These are all vasodilators, and vasodilators are going to worsen rosacea. Whereas in a patient of SLE, we are going to have systemic features. Systemic features are fever, joint pain, oral ulcers. Fever, joint pain, and oral ulcers. Second point is pertaining skin lesions. The various skin lesions of rosacea we've already discussed. Centrofacial erythema, flushing, telangiectasia. You can also have papulopustules. So these are the variety of lesions which you can get in rosacea. Whereas in SLE, what you're going to have? You're going to have erythema, which is also known as the butterfly rash. And in terms of distribution, this also I've already discussed. You have the central convexities of the face which is getting involved here. Whereas SLE, you have the malar area plus bridge of the nose gets involved. So if there's malar area plus the bridge of the nose gets involved, then it is going to be feature suggestive of systemic lupus erythematosus. So always remember, students, you cannot distinguish with one point. There are multiple points here. So keep everything in mind, then only mark your answer in the exam. So here we can see a patient of rosacea who has this flushing, and those will be the features which are going to be mentioned. And here we have a patient of a malar rash, also known as the butterfly rash, and here generally the nasolabial fold also tends to be spared. The next topic is skin and systems. Case scenario number 1. There's a question which is telling us that there's an adult male presenting with asymptomatic skin lesions distributed over the anterior aspect of the leg. Two important differential diagnoses is what we need to consider. Number 1, NLD, which stands for necrobiosis lipoidica diabeticorum. So necrobiosis lipoidica diabeticorum. This is the first differential diagnosis. Second important differential diagnosis here is pretibial myxedema. Pretibial myxedema. Now let us see how to distinguish between NLD versus pretibial myxedema. So how to distinguish between these two conditions is in necrobiosis lipoidica diabeticorum. See, the word lipoidica is there. That is why we can see there is lot of yellowish discoloration in the plaque here. So you get a waxy yellow atrophic plaque. And carefully, if you observe, you can also see this reddish tinge over here. This is referred to as surface telangiectasia. This is referred to as surface telangiectasia. So waxy yellow atrophic plaque with surface telangiectasia is the morphology, and the distribution is anterior aspect of the leg. The association, that's why this is called diabeticorum, is diabetes mellitus. Is diabetes mellitus. The second condition is pretibial myxedema. How will pretibial myxedema present? Non-pitting type of diffuse edema. Non-pitting type of diffuse edema. Please remember, students, many get confused in the exam. The word, if myxedema is mentioned, it is hypothyroidism, but pretibial myxedema is associated with Graves' disease, which is hyperthyroidism. And please keep this point in mind, that pretibial myxedema is also referred to as thyroid dermopathy. It is also referred to as thyroid dermopathy. Next is pediatric dermatology. In pediatric dermatology, let us take up case scenario number 1. So there is a child presenting with fever and maculopapular rash on day 4 of the illness. So child, fever, maculopapular rash, day 4 of the illness. Two important differential diagnoses to consider. Number 1, measles. Number 1 is measles. Number 2, sixth disease. Sixth disease. So students, please remember, pediatric question in the exam, the other names for sixth disease. Number 1, exanthum subitum. Exanthum means rash on the body. Subitum means abrupt, sudden high fever. Suddenly the fever comes down, suddenly the rash appears. So this is one thing you need to remember. Exanthum subitum is also referred to as roseola infantum. Roseola infantum. So we have these two important differential diagnoses in mind. How do we distinguish between measles and roseola infantum? Number 1, first is the site of the rash. Please remember, measles, the rash is going to start on the face behind the ears, and then it is going to be progressing to the neck, trunk, and extremities. So it is going to follow this kind of a pattern. Whereas roseola infantum, generally the rash starts on the trunk and moves outwards, and face is generally spared. Face is generally spared. So the rash starts from the trunk and moves outwards, and generally face is spared. The second point here is with the onset of rash. What will happen in measles with the onset of rash? The fever increases for the next 2 to 3 days. Very, very important point. What is going to happen with roseola infantum? With the onset of the rash, fever decreases. Fever decreases. Very, very important clue, students, to pick up in an MCQ exam. Next is the fate. How is measles going to heal? It leaves behind residual hyperpigmentation. Residual hyperpigmentation is going to be there. Whereas here, residual hyperpigmentation is going to be absent. And in the oral cavity, this was this year's NEET PG exam question, Koplik spots. You're going to be having Koplik spots which are seen across the buccal mucosa. Whereas in roseola infantum, the name of the spot is Nagayama spots. Nagayama spots. These are also referred to as uvulopalato-glossal spots. So these red color papules are distributed over the uvula and the tongue. That is what you need to remember, together with the palate. That's why it's called as uvuloglosopalatal spots. Very, very important points to distinguish between measles and roseola infantum. So this is the measles rash, which I told you starts behind the ear, goes to the neck, trunk, and the extremities, leaves behind hyperpigmentation, whereas sixth disease starts from the trunk, moves outwards, and face is spared in roseola infantum. Case scenario number 2. Question is saying in the exam, child, fever with a vesicular rash. So please remember the word vesicle. Vesicle is a fluid filled lesion which is measuring less than 1 centimeter. So child fever, vesicular rash, two important differential diagnoses in the exam. Number one, varicella. Number two, hand, foot, mouth disease, HFMD. So how do we distinguish between varicella and hand, foot, mouth disease? Number one is the site of the rash. So please remember, what is the distribution of varicella? Varicella mainly involves the trunk. It is centripetal in distribution. Whereas if you look at hand, foot, mouth disease, it is mainly acral in distribution. When you say acral, what I mean is palms, soles. But apart from palms and soles, please remember buttocks and oral cavity can also have lesions. So this is first point you need to remember. The second point is going to be regarding the morphology of the rash. So initially in varicella, we get macules, then papules, then vesicles, then pustules, then scab. So these are the stages of the evolution. But please remember, what is special about varicella is all these stages can be present simultaneously at the same time. This is referred to as a pleomorphic rash. This is referred to as a pleomorphic rash. Whereas in hand, foot, mouth disease, generally you have papulovesicles which tend to ulcerate. So this pleomorphic rash is a very characteristic feature which is seen in varicella. So here we can see a child with varicella. You can see these vesicles on red base, This is also referred to as dewdrop on rose petal appearance. Dewdrop on rose petal appearance, which is very, very classical for a varicella patient. And this is a patient of hand, foot, mouth disease. You can see these oval vesicles here distributed over the palms, soles, buttocks and oral cavity. Very, very important is hand, foot, mouth disease, which is produced by Coxsackie A16 and enterovirus number 71. So these are the causative agents of hand, foot, mouth disease. We are going to be discussing infectious diseases, which is going to be extremely high yield for your exam. These are the overlap topics between microbiology and dermatology. We'll take up the first case scenario here. The first case scenario is of an agricultural worker who gives history of trauma, presenting with a verrucous or a warty plaque on the foot. So first we'll try to understand, whenever there is a word called verrucous in dermatology, what does it mean? It means anything in dermatology which is going to be having a rough or an uneven surface. Rough or uneven surface. That is why it is also known as a warty plaque, rough, uneven surface. Two important differential diagnoses to consider. Number one, tuberculosis verrucosa cutis. Tuberculosis verrucosa cutis. Number two, chromoblastomycosis. Chromoblastomycosis. So these are the two important differential diagnoses, TBVC and chromoblastomycosis. Now, this is how a TBVC presents. You can see this warty plaque which is there on the foot. How to distinguish? Get a Mantoux test done. So this is a Mantoux test. Positivity is going to be noted in tuberculosis verrucosa cutis. Chromoblastomycosis is also referred to as verrucous dermatitis. It is also referred to as verrucous dermatitis. And please remember, student, the meaning of the word chromo. Chromo means color. Chromoblastomycosis is produced by pigmented fungi. It is produced by pigmented fungi. Now, pigmented fungi means dematiaceous fungi. Dematiaceous fungi. That means these fungi have got color in their structure itself. And here you can see this warty plaque which is there on the foot. The best way to identify this condition is do a potassium hydroxide mount. And what you see here is this brown, round, thick-walled bodies. These brown, round, thick-walled bodies are called copper pennies. Copper penny bodies, also known as sclerotic bodies, also known as medlar bodies. So please remember, these are the three names for these brown, round, thick-walled bodies. The treatment for this condition is itraconazole. The treatment of this condition is itraconazole. Second case scenario in infectious diseases, there is an adult male presenting with hypopigmented macules on the trunk. So when there is an adult male, hypopigmented macules on the trunk, three important differential diagnoses to consider. Number one, pityriasis versicolor. Number 1, pityriasis versicolor. Number 2, Hansen's disease. Number 2, Hansen's disease. Number 3, post-Kala Azar dermal leishmaniasis, PKDL. So 3 important differential diagnoses: pityriasis versicolor, Hansen's disease, and number 3 is post-Kala Azar dermal leishmaniasis. First, let us look at pityriasis versicolor. What kind of lesions are we going to get here? We are going to get perifollicular lesions. So here, we know that Malassezia, furfur or globosa is going to be targeting the hair follicle, so perifollicular scaly lesions. Number 2, the scales in pityriasis versicolor are referred to as fine, brany, furfuraceous scales. Fine, brany, furfuraceous scales. So this is the scaling of pityriasis versicolor. Next important site is going to be trunk. And fourth point is a clinical sign. So what I do is I take my nail and scratch the lesion. The scaling becomes prominent in pityriasis versicolor. This is referred to as scratch test, also referred to as Besnier's sign. Also referred to as Besnier's sign. So all we have to do is take our nail and scratch the lesion. Scaling becomes prominent. And to confirm the diagnosis, you have to do a potassium hydroxide mount. You get short hyphae plus round spores. Short hyphae are compared to spaghetti. Round spores are compared to meatballs. That is why this is referred to as spaghetti and meatball appearance, very classical of pityriasis versicolor. Next differential was Hansen's disease. Now usually in an exam scenario, a patient of Hansen's is going to be from one of the endemic regions for Hansen's. So an endemic region like Bihar, UP, Tamil Nadu may be mentioned in the exam. Number 2, please remember what goes against Hansen's is Hansen is a non-scaly condition. Third thing is sensation. So please remember, sensation is impaired in Hansen's but can be normal in lepromatous leprosy. In lepromatous leprosy, the sensation over the skin lesions may be normal, but most of the other times there is impaired sensation in Hansen's. Next is peripheral nerve examination. Please remember, Hansen is more of a disease of the nerve than skin, so nerve is very, very important. There is peripheral nerve thickening here. And lastly, you do the slit skin smear for acid fast bacteria. You will get positive for acid fast bacteria. So the definitive diagnosis is going to be by a slit skin smear for acid fast bacteria. The next important differential diagnosis is post-Kala Azar dermal leishmaniasis. So here what is the history? Again, the history is going to be of an endemic region for leishmaniasis or rather visceral leishmaniasis. So Bihar may be mentioned in the question. The second point is what past history would I want to elicit? So please remember, this is post-Kala Azar dermal leishmaniasis. So what is Kala Azar, students? Please remember, Kala Azar is called as visceral leishmaniasis. So how do I elicit history of visceral leishmaniasis? There will be past history of prolonged fever. So prolonged fever in the past is one clue which is going to tell you probably the patient has visceral leishmaniasis. We also know that visceral leishmaniasis is going to present with massive splenomegaly, right? The two important points of visceral leishmaniasis. The next important point, sensations are always normal here, and then peripheral nerves are not involved. Peripheral nerves are not involved in post-Kala Azar dermal leishmaniasis. And very important is the definitive diagnosis is by a crust tissue smear. So when you look at the crust tissue smear, you get LD bodies. Please remember, microbiology question, amastigote form. Amastigote form. So here also you can see multiple hypopigmented macular lesions. Looks exactly like Hansen's. The only way to distinguish is the nerve parameter. Peripheral nerve thickening present, you go for Hansen's disease. If it says it is normal, then consider post-Kala Azar dermal leishmaniasis. Next case scenario. There is an adult male presenting with swelling over the foot with discharging sinuses. So foot, swelling, sinus formation, what should I think? Very, very important. Number 1 is mycetoma. This is my first DD. Second is going to be bacterial pseudomycetoma. Bacterial pseudomycetoma. So please remember, students, the other name for bacterial pseudomycetoma is botryomycosis. Botryomycosis is the other name for bacterial pseudomycetoma. Now we know the classical triad of mycetoma. You have swelling formation, sinus formation, and then you have discharging granules. Now please remember, mycetoma is divided into eumycetoma and actinomycetoma. And eumycetoma, we should remember, is fungal in origin. So you do the appropriate cultures, investigation, look for fungi. And actinomycetoma is produced by filamentous bacteria. Filamentous bacteria. So the main way to distinguish it is microbiologically look at the cause. Whereas if I'm talking about botryomycosis or bacterial pseudomycetoma, please remember the most common organism here is going to be Staphylococcus aureus. So in the culture, you are going to be looking for microbiological features of Staph aureus. So please remember, clinically, it is almost impossible to distinguish between mycetoma and botryomycosis. You have to use the microbiology department's help to help you distinguish the causative organism, and that will change your diagnosis. Case scenario number 4. Now, if we look at this case is talking about a patient presenting with fever and sheet-like epidermal peeling. So when you get these pickup points, fever with sheet-like epidermal peeling, two important differential diagnoses to consider. Number 1, staphylococcal scalded skin syndrome. So this is number 1. And number 2 is toxic epidermal necrolysis. Toxic epidermal necrolysis. So how are we going to distinguish these two conditions? First, let's take up staphylococcal scalded skin syndrome. So here, there always will be a history of distant focus of infection. So when I say distant focus of infection, it could be in the conjunctiva. It could be in the ears. So the focus could be conjunctivitis, it could be otitis media. Second important is the mechanism. Now please remember here, Staphylococcus aureus produces a toxin, and this toxin is responsible for splitting the skin. So please remember the mechanism here is acantholysis. Okay, it is toxin mediated, and this is going to be producing acantholysis. That's a very important mechanism. Third, the initial features here. So please remember, one of the initial features will be periorificial erythema. So you're going to have redness around the orifices. That's periorificial erythema. And why are we discussing this topic? Because the differential diagnosis of fever with sheet-like epidermal peeling. You can see some sheet-like epidermal peeling happening there. So what is the other important point to remember? The clinical sign. Whenever the sheet-like epidermal peeling is Nikolsky sign. And we've already studied in bullous disorders. When the mechanism is acantholysis, we are going to be having true Nikolsky sign. True Nikolsky sign. And then we examine the oral cavity. Please remember, students, when this toxin I was talking about, this is going to cleave desmoglin number 1. And please remember, we already studied it in bullous disorders. Desmoglin 1 is expressed in low concentration in the oral cavity. Higher concentration in the oral cavity is desmoglin 3. So because desmoglin 1 is targeted, mucosa is normal in this condition, just similar to pemphigus foliaceus. So we also have studied in bullous disorder, desmoglin 1 is involved in pemphigus foliaceus. That is why in both these conditions, mucosa is not involved. Whereas when I'm talking about toxic epidermal necrolysis, number 1, history. There will be history of drug intake here. It could be an anti-epileptic, it could be allopurinol, it could be an ART, antiretroviral therapy. Second thing is the mechanism. What happens over here, students, in toxic epidermal necrolysis? You're going to be having keratinocyte necrosis. Keratinocyte necrosis. And please remember this point, that the keratinocyte necrosis happening in TN is involving full thickness of the epidermis. Full thickness of the epidermis is going to be involved here. The initial feature of toxic epidermal necrolysis is going to be atypical target lesions. Atypical target lesions. So generally when we learn in dermatology, target lesion is a lesion in dermatology seen in erythema multiforme, which has 3 zones. Atypical target lesions have got 2 zones. Okay, that's important. And then the clinical sign that we want to elicit here is called pseudo-Nikolsky sign. So true Nikolsky sign The mechanism is acantholysis. Pseudo-Nikolsky sign, which is giving tangential pressure over the skin, is elicited over here. And here the mechanism is keratinocyte necrosis. Very, very important. When we define in our regular classes what is the definition of TN, we call it as acute, life-threatening, severe, mucocutaneous drug reaction. That means mucosa should be involved in a patient of TN. So here you're going to get hemorrhagic crus. Here we're going to get hemorrhagic crus. So these are the key points to distinguish between SSSS and toxic epidermal necrolysis. Now let us take up some case scenarios, very, very important in the exam in sexually transmitted diseases. Number 1, an adult male with history of high-risk exposure. So high-risk exposure means exposure to sexually transmitted infections, presents with asymptomatic skin-colored lesions on the genitals. So when I say asymptomatic skin-colored lesions on the genitals, I have 2 important differential diagnosis, students. Number 1, condyloma acuminata. The second important differential diagnosis here is condyloma lata. So these are the 2 important differential diagnoses to consider. Now let us see how to distinguish between the 2. First is the etiology. Please remember, condyloma acuminata is produced by HPV 6 and 11 low risk types in 90% of the patients, and HPV 16-18 high risk types in 10% of the patients. So majority of the times it is going to be the low risk types, and rarely it can be high risk type, because this also has been asked in the previous NEET exam questions. The causative organism of condyloma lata is going to be Treponema pallidum, because this is a form of secondary syphilis. This is a form of secondary syphilis. The second point here is morphology. Now, when I look at the word acuminata, what is the meaning of the word acuminata? Pointed. So the patient is going to present as asymptomatic, fleshy, pointed, pink papules and plaques. Asymptomatic, fleshy, pointed, pink papules and plaques, whereas condyloma lata, the meaning of the word lata is flat. So flat topped, moist papules and plaques. So now we understand how do we distinguish. So please remember that acuminata means pointed lesions, lata means flat lesion. The next important point is what investigation I want to do. Here, the investigation I want to do in a condyloma acuminata is going to be called as histopathology, and I'm going to get a cell called as koilocyte. Now, koilocyte is a cell which we read repeatedly in pathology. It is described as a squamous epithelial cell, hyperchromatic nucleus, and a perinuclear halo. That is a koilocyte. Whereas when we are talking about condyloma lata, we are talking about secondary syphilis. And please remember, students, the best investigation in a patient of secondary syphilis is VDRL or RPR. So VDRL or RPR is the best investigation for secondary syphilis. Now here we can see in the image here, you can see this asymptomatic, fleshy, pointed, pink papules and plaques. So usually they are seen on the coronal sulcus and they are seen on the frenulum. These are the most important sites for friction during a sexual intercourse. And what do we see in condyloma lata? Lata means flat. So we can see this flat topped, moist papules and plaques over the genital area. Go for the diagnosis of condyloma lata. Lata means flat. The treatment of condyloma acuminata, just for completion purpose, number 1 is podophyllin and number 2 is imiquimod. So podophyllin is a drug which is going to be targeting the mitotic spindle and it produces wart necrosis. Imiquimod is a toll-like receptor number 7 agonist. So it's a TLR. TLR, please remember, students, is toll-like receptor number 7 agonist. It stimulates your immune response. Whereas condyloma lata, I want to give injection benzathine penicillin 2.4 million units, deep IM, single dose. Now the question is, why should I give only single dose? So please remember, students, condyloma lata is secondary syphilis and secondary syphilis is classified as early syphilis. So please remember, in early syphilis, all that we have to do is give a single dose of injection benzathine penicillin, 2.4 million units, deep IM. After a test dose, single dose. Next case scenario, number two, an adult male with history of high risk exposure. Again, high risk to sexually transmitted illnesses and urethral discharge. That means the question is asking me about urethritis. Now, when I'm looking at urethritis, we have two important differential diagnoses here. One is gonococcal urethritis, and the second one is non-gonococcal urethritis. So these are the two important DDs, gonococcal and non-gonococcal urethritis. Now, how to distinguish the two? First, we look at the incubation period. The incubation period is a short incubation period of 2 to 5 days. Non-gonococcal, it is going to be 7 to 14 days. When we talk about dysuria, please remember students, when you're studying this table, gonorrhea is a severe disease. So you're going to be having severe dysuria here. Whereas in non-gonococcal urethritis, the dysuria is going to be variable. Talking about the urethral discharge. Now, what is the meaning of the word gonorrhea? Gono means seed, rhea means flow. That means the discharge is flowing out. You are going to be having profuse, purulent discharge. Profuse, purulent urethral discharge is the feature here. The opposite of profuse is scanty. The opposite of purulent is mucoid discharge. So scanty mucoid urethral discharge is a feature of non-gonococcal urethritis. Let us now move on to the investigation. In investigation, what do I want to do for gonococcal urethritis? I want to do a gram stain. And on gram stain, what am I looking for in Neisseria gonorrhoeae? Gram negative intracellular diplococci is going to be suggestive of Neisseria gonorrhoeae. And when we look at the causes of non-gonococcal urethritis, we have multiple causes. There is ureaplasma, there's mycoplasma, there's trichomonas vaginalis. Please remember, students, the most common cause is going to be chlamydia trachomatis, chlamydia trachomatis D2K serovar. This is what everybody should remember, the most common cause. And generally for chlamydia, the best investigation to do is NAT. NAT stands for nucleic acid amplification test. So here we can see the profuse purulent urethral discharge seen from the urethral meatus of a patient after a short incubation period is suggestive of gonorrhea. If we look at the treatment of gonococcal urethritis, first we want to give injection ceftriaxone 500 mg IM in a patient who is less than 150 kgs. Plus, I want to add doxycycline 100 milligram BD for 7 days. But please keep this point in mind. CDC clearly mentions you have to give doxycycline if chlamydia is not excluded. If chlamydia is not excluded, definitely you should be giving doxycycline 100 milligram BD for 7 days. When we look at the treatment of non-gonococcal urethritis, number one, we go for tablet azithromycin, 1 gram stat, or doxycycline, same dosage again, 100 milligram BD for 7 days. 100 milligram BD for 7 days. The next topic is syndromic management of urethral discharge. Now, syndrome refers to a collection of symptoms and signs. So, in order to treat an STD based on symptoms and signs, the National AIDS Control Organization has come up with kits. When we are going to be treating urethritis or cervicitis, we need to remember that we are using kit number 1, which is grey in color. So, it is used for urethritis, cervicitis. Now, please remember, cervicitis means on per speculum examination, if you have cervical erosion, ulcer, discharge, you have to use kit number 1 and anorectal discharge. Two important drugs are given here. Number 1, cefixime 400 mg 1 stat. This is going to be covering gonococci. And the second important one is you're going to give azithromycin 1 gram stat. This is to cover chlamydia. This is for the coverage of chlamydia. Case scenario number 3, adult female presents with vaginal discharge. 3 important differential diagnoses we want to consider apart from the physiological causes. Number 1, we are looking at candidiasis, trichomoniasis, and number 3, we're looking at bacterial vaginosis. So most of us know that candidiasis is produced by Candida species. Trichomoniasis is produced by Trichomonas vaginalis. And bacterial vaginosis, please remember, it is not an STD. It's not sexually transmitted disease. So what is it? It is a altered vaginal microflora. It is altered vaginal microflora. That's what we need to have a concept about bacterial vaginosis. That's why we don't have to treat the partner in bacterial vaginosis. Now, first we look at candidiasis. The type of discharge that we get here is called as curdy white discharge. Curdy white vaginal discharge. Next, we look at trichomoniasis. In trichomoniasis, 2 points to remember. Number one is greenish yellow frothy discharge. Greenish yellow frothy vaginal discharge. One more important cervical finding where you get multiple punctate hemorrhages over the cervix. You can see this multiple punctate hemorrhages over the cervix. This is referred to as strawberry cervix. This is going to be getting the name of strawberry cervix. Very important for trichomoniasis. And then bacterial vaginosis, how do I describe the discharge? Homogeneous, white, adherent discharge. So homogeneous, white, adherent discharge. And when we look at the syndromic management of vaginal discharge, we are going to be using kit number 2, which is green in color for vaginal discharge. And we have these important drugs to remember. Number 1 is going to be tablet fluconazole, 150 mg, 1 stat. This is going to be covering the spectrum of candida. And the second drug is secnidazole, 1 gram BD. So this is going to be covering bacterial vaginosis and trichomoniasis. Case scenario number 4. So adult male with history of high risk sexual exposure presents with genital ulcers. Now when the word genital ulcer is given in the question, I immediately have to think about genital ulcer diseases, which are 5 in number. So the best way to approach this question is to classify the causes of genital ulcers. So broadly we can classify them like this into single and painless ulcers, multiple and painful ulcers, also known as multiple and tender genital ulcers. So here in the first category there are 3 causes. In the second category there are 2 causes. Now which are the 3 important STDs which present with single painless ulcers? Number 1 is primary syphilis. Number 2, donovanosis. Number 3, lymphogranuloma venereum. So these are the 3 STDs which are single and painless. Which are the STDs which are multiple and tender? Chancroid and genital herpes and genital herpes. Now, whenever there's a single painless genital ulcer, we have already kept those 3 causes in mind. Now, how do I further segregate them? I immediately look at the inguinal lymph nodes. This is very, very important. So, suppose the question says inguinal lymph nodes are painless. Then I'm going to mark it as primary syphilis. Suppose the question says inguinal lymph nodes are painful. Then I'm going to be marking as lymphogranuloma venereum, where you also get something known as a bubo, which is a suppurative lymph node. And if the question says there's a single painless genital ulcer with no inguinal lymph nodes involved, then I will mark my diagnosis as donovanosis. Now please remember students, the other name for donovanosis is granuloma inguinale. Granuloma inguinale. Now let us see the ulcer of primary syphilis. So primary syphilis is also referred to as hard chancre. Also referred to as hard chancre. So you can see this single ulcer over here. So how do I describe this single ulcer? It is described as single, clean based, indurated ulcer. Please remember students, that is why it is called as hard chancre. So it's single, clean based, indurated, non-tender, and there's no bleeding on touch. So this is the characteristic of a genital ulcer of syphilis, and the investigation of choice from this ulcer is going to be dark ground microscopy. So dark ground microscopy of the ulcer exudate, where I'll be looking at the motility, the corkscrew motility of the Treponema pallidum. Here we have the second important example. You look at this ulcer. This is the classical ulcer of donovanosis, which is produced by Klebsiella granulomatis. Please remember, it is not Leishmania donovani. Donovanosis is produced by Klebsiella granulomatis. And here, this is described as a beefy red ulcer which bleeds on touch. Beefy red genital ulcer which bleeds on touch. This is going to give me a differential diagnosis of donovanosis, and inguinal lymph nodes are normal. Only thing is, in the groin, you can get a subcutaneous nodule, and this subcutaneous nodule, which is seen in donovanosis, this is called as pseudobubo. This is going to be seen in donovanosis. This is going to be seen in donovanosis. And when I'm talking about multiple tender genital ulcers, again I talk about inguinal lymphadenopathy. If the inguinal lymph nodes are painful, but there is a suppurative bubo, if there's bubo formation, bubo means the lymph node is enlarged with pus formation, then I will mark my diagnosis as chancroid. Whereas if the question says there is enlargement of lymph nodes, there is painful inguinal lymphadenopathy, but no bubo. If bubo is absent, then I can mark my diagnosis as genital herpes. So please remember, students, usually if the examiner wants you to mark genital herpes, there will be history of vesicles prior the ulcer. So if the question says there are vesicular lesions, fluid filled lesions prior to the onset of the ulcer, then I can mark my diagnosis as genital herpes. So here we can see in the picture, you can see these multiple tender ulcers. Please remember, this is also referred to as soft sore or soft chancre. Hard chancre is seen in primary syphilis. Soft chancre is seen in chancroid, which is produced by Haemophilus ducreyi. And we know what investigation we want to do. We want to do a gram stain. We want to be looking for gram-negative cocobacilli. Gram-negative cocobacilli, which are arranged in long parallel strands. So gram-negative cocobacilli arranged in long parallel strands. This is referred to as school of fish appearance. School of fish appearance, also referred to as railroad track appearance. Railroad track appearance. So this is the classical microscopy of Haemophilus ducreyi. Whereas when I'm looking at genital ulcer disease due to herpes, you can see these multiple ulcers which are grouped, and then you also see some ulcers wherein these separate ulcers have merged together to form this very classical polycyclic margins. Polycyclic margins. And to repeat once again, please remember, students, that genital herpes is usually preceded by vesicle formation. Let us take up case scenarios in relation to Hansen's. Case scenario number 1, child presents with hypopigmented macular lesions on the face. Two important differential diagnoses to consider. Number 1, pityriasis alba. Pityriasis alba. The second important differential diagnosis here is indeterminate Hansen's disease. Indeterminate Hansen's disease. So child, hypopigmented macules on the face. Think about these two conditions, pityriasis alba and indeterminate Hansen's. Now, how do we distinguish these conditions? The first point is history. So pityriasis alba is a type of endogenous eczema. Okay, it is usually seen in children with dry skin. So there will be history of atopy. If you remember, in the previous model, I've already mentioned atopy means recurrent allergic rhinitis, bronchial asthma, and atopic dermatitis. That is called as atopy. And in indeterminate Hansen's, what history is going to be there? The child presenting from an endemic region for leprosy, Bihar, UP, Tamil Nadu. So Bihar, UP, Tamil Nadu will be given in the question because it is seen in indeterminate Hansen's. Next important point is scaling. Please remember, pityriasis means scaling. So here scaling is present. In leprosy, scaling is absent. Next, let's talk about sensation. Sensations are normal in P. alba. Please remember, in indeterminate also the sensation is normal because it represents the early stage of leprosy. Sensation is not lost here. Another way, if you are in confusion, is to do a histopathological examination. On histopathology, we know that pityriasis alba is an eczema, so we can expect spongiosis. So what is spongiosis, students? It is intraepidermal intercellular edema. So in the epidermis, between the cells, if you get water, this is called as spongiosis. Whereas in a patient of indeterminate Hansen's disease, what will we get? We are going to be getting perineural and periappendageal. So we are going to get perineural around the nerves, around the appendages like sweat glands, sebaceous glands, lymphocytosis. That is why the investigation of choice for indeterminate leprosy is skin biopsy. Skin biopsy. Here you can see vague, hypopigmented, scaly macular lesions over here. So this is pityriasis alba. This is a child with indeterminate Hansen's disease. Next case scenario, there is an adult male with Hansen's. So the case scenario is telling it is a leprosy patient. He's been started on multibacillary multidrug therapy, which is the standard treatment for Hansen's. Develops signs of inflammation. Is developing signs of inflammation. So we should know, whenever we talk about Hansen's, we are talking about a chronic process. And here, what the question is trying to tell us is, in a chronic process like Hansen's, if something acute happens, what is my diagnosis? My diagnosis will be lepra reaction. Okay, my diagnosis is lepra reaction. There are two important forms in India to consider. Number one, type 1 lepra reaction and type 2 lepra reaction. So type 1 lepra reaction and type 2 lepra reaction, these are the two forms of lepra reaction. Now let us look at this very, very important table frequently asked in the exam. How do we distinguish the two? Now please remember, type 1 lepra reaction is usually seen in which spectrum of the disease? It is seen whenever the word borderline comes. And there are three situations where you can get the word borderline: BT, BB and BL. Whereas when I'm looking at type 2 lepra reaction, I'm talking about the word lepromatous spectrum. And we know in Hansen's, there are two forms of Hansen's where the word lepromatous comes. So we have BL and LL leprosy. Now what type of hypersensitivity reaction is type 1? Type 1 is an example for type 4 hypersensitivity reaction, which is the delayed type. Type 2 is characterized by immune complex formation. So it's an example for type 3 hypersensitivity reaction. And when we're looking at skin lesions, please remember, I was talking about acute inflammation during the course of leprosy. So if the existing skin lesions become red and tender, so please remember the key word here is existing skin lesions become red and tender. This is called as type 1 lepra reaction. If there is emergence of new red, tender nodules. So if there is emergence of red, new, tender nodules, my diagnosis is going to be type 2 lepra reaction. Please remember, the other name for type 2 lepra reaction is ENL. ENL stands for erythema nodosum leprosum. Erythema because it is red in color. Nodosum because you get nodular lesions. Leprosum in the lepromatous spectrum. That's why this condition is called as erythema nodosum leprosum. Next we look at nerve involvement. In type 1 lepra reaction, you have very severe neuritis. So very severe neuritis is a feature of type 1 lepra reaction. Whereas in type 2 lepra reaction, nerves may be involved or may not be involved. But when talking of systemic features are generally absent in type 1 lepra reaction. Whereas in type 2, as I told you, there is antigen antibody forms an immune complex. It can go and deposit all over the body. The patient has got fever, can have iridocyclitis, can have arthritis, orchitis, glomerulonephritis. So you can have multiple types of systemic involvement in type 2 lepra reaction because it is an immune complex mediated disease. So here you can see this was a patient who had a hypopigmented patch on the face. And what happens in type 1 lepra reaction? How am I going to identify it in the exam? The examiner will tell you the existing lesions of Hansen's have become red and tender, mark type 1 lepra reaction. Very severe neuritis is associated. Whereas in type 2 lepra reaction, you can see these multiple nodular lesions. So obviously, by looking at this picture, you can't make out a nodule. You can just see the erythema, right? That is because a nodule is a lesion which is felt. It is a deeper lesion in dermatology, and these erythematous nodular lesions are referred to as ENL, erythema nodosum leprosum. And please remember, whenever type of lepra reaction is asked in the exam, please remember the principle of treatment is always going to be continue multi-drug therapy. So please remember, do not stop the multi-drug therapy thinking that the patient has developed acute inflammation. And if they ask you drug of choice, it is systemic steroids. It is going to be systemic steroids. With this, we conclude a session on clinical vignettes in dermatology. Thank you.